Bacon and others, very disciplined method of scientific approach. And so Descartes said, doubt everything but doubt itself. And Isaac Newton's famous third law of for every action there's an equal and opposite reaction really simplified for the 17th century mind and made things very determinable. Then in the 18th century, there was an enlightenment, and there's a picture there of Friedrich Nietzsche, who was a proponent of perspectivism, of thinking beyond just the world as a machine. It was really in the early 1900s that the new physics challenged the Newtonian concept of symmetry between cause and effect. And, of course, at the subatomic level, things get very, very complex. So that brings us then into the 20th century, and with Alfonso Chapanas, who was really the father of human factors. The reason I put this slide up here is that I will refer back to Newton and Descartes and their grasp on it. So I'll hand it over to Alison again.
Okay. So this is one of my favorite comics that I'm sure some of you have seen before. But basically what this is showing us is the mixing up of buttons. Our little bank teller there is thinking why you would put the emergency button next to the eject button is beyond me as her code teller is being launched out of the scene. So in a bank, it might be fortuitous to be launching yourself out of a bad situation like this. But in healthcare, if you're mixing up buttons or if you're mixing up medications, it obviously can lead to some very serious consequences. And so when we talk about human factors, what exactly are we talking about? And this is one of my favorite definitions. It's by Chapanas. What human factors is ultimately designing for human use. And what that means is it's a body of information about human abilities, human limitations, and other human characteristics that are relevant to design. So these can be anything from fatigue to distraction to interruptions, reaction times, anything that is involved with how people are basically functioning within their environment. Now, when we apply it to human factors engineering, what we're really talking about is actually applying that body of information to understanding how tools, machines, systems, tasks, jobs, and environments for safe, comfortable, and effective human use are designed. And so for the purpose of this presentation, we'll primarily be talking about systems, but just note that it can relate to these other areas as well.
In the World Health Organization has a definition of human factors, and I use the title A definition there as well. And you'll see from the components on that slide that it includes a lot of the work that we would probably conceptualize as quality improvement, patient safety, lean methodology, all that sort of work. It has a few catchwords in there like situation awareness, which is a very aviation-oriented sort of thing historically, as human factors is, and a lot about stress and fatigue in the workplace, and fundamentally looking from the practitioner's perspective on how they relate to the environment rather than the other way around. Marianne?
Great. So what we're really trying to convey is that it's a multidisciplinary approach. So I don't think you'll be able to see this slide from the webinar, but what this shows is actually there's a multidisciplinary approach to human factors, and it involves things like psychology, anthropometry, so actual physical body measurements, applied physiology and medicine, and engineering. But then it also goes into other areas like statistics and operations research, industrial design, and then system safety. And so there's a multifaceted approach that most human factors people have varying different backgrounds and approach problems with that information that they've learned in the past. And so when human factors is applied, there's two different perspectives that can be taken. The first is the physical or human perspective, where you're looking at elements like the user or the environment or the technology, but you tend to be looking at those items independently of each other. So when you think of a critical incident happening and the user is immediately blamed for being the cause of that problem, that would be an example for this situation. Whereas a system perspective looks at the user, the environment, the patient, or the technology, and it looks at it all together. And so it's drawing an imaginary system boundary around these components, looking at them independently, but then also looking at how they have relationships with each other. And one of the examples that I can explain with this would be medical devices, where independently a medical device is safe in one institution, but with the constraints of other technology in another place, it could lead to some safety concerns. So our assumptions as human factors specialists are that a perfectly designed system will be easy to use and minimize adverse events, whereas a poorly designed system will be difficult to use and be prone to adverse events. And so what our goal is as human factors specialists is to apply these methods to evaluate the differences and make recommendations for improvements to support human work. So some of the areas that I've been involved in applying human factors in the healthcare side include the following. The first one is rather obvious. It's the reduction of adverse events. And so if a critical incident happens or if there's an investigation, it's looking into how these problems have occurred and making recommendations or solutions to solve these problems. The second one is increasing safety, and this is more of a proactive approach as well. And it involves things like medical device selection, actually understanding how technologies are interacting beforehand and selecting a technology that is safe to use. The third one is impacts to users and operators, which involves things like fatigue or distractions or interruptions and the complexities of those users' environments. And then finally, improvements to system performance, which Ray is going to talk about a little bit as well. But this is the most complicated and I would say most timely and costly approach, but it does it does present the largest results. So ultimately, why is this important? Well, the performance of the system depends on the user. So you can have the most fantastic system designed, and it could be the latest in technology, but if people don't like it or they're uncomfortable using it, they'll sit on a shelf and gather dust. Now, if you force people to use it and incorporate it into their workflow, most often you see workarounds or people shortcutting in completing the tasks. And these are the areas where an increase in error is probable and likely. The second is that users are adaptable and can learn to use poorly designed systems. And we see this time and time again in the hospital. But personally, I've seen this with my fiance, who's involved in heavy construction. But when you place him at our cottage with his brother and his father on a boys' weekend, putting on the roof of our cottage, somehow folding chairs on top of scaffolding seemed like a good idea. And finally, we cannot assume that all users can complete a task simply because you can. When I was involved in doing research and development down in the States, I'd be working with engineers and they would be saying that, oh, we've designed this really neat system, and I'd go and trial it with actual end users and they couldn't use it. You'd bring it back to the engineers and they'd say, well, I can use it, why can't they? And ultimately, it's ensuring that it's being designed for the people who are using it the most.
This is a slide I love. I think this genie was employed by the engineering company who made the software. If anyone's, those of you out there who have used Meditech in the past, DOS-based system, state-of-the-art in the 70s, you will know this frustration of trying to do critical or clinical care in that cumbersome system. So it's all about designing the system around the user, not the other way around.
So what is human error? I know I've touched on this a little bit. I'm going to give you a definition and then I'm going to let Ray jump in. And so when we talk about human error, it's used quite often, specifically in healthcare now, but it's considered as a definition inappropriate human behaviors that lower levels of system effectiveness or safety, which may or may not result in accident or injury. So I'll pass it over to you, Ray.
Okay, thanks. There are some schools as well that contend that human error is not a terribly useful term, actually. I'll just go into a little bit of background of where human factors came from the aviation world. Maybe Andrew, do I have slide capability here, Andrew?
We'll move them from here, okay?
Okay, yeah, that'd be great. So the next slide, please. So this is a picture of a World War II aircraft. Very nice in flight. This is a picture of the same type of aircraft on the ground. What's interesting, I think, in this picture is if you look at the propellers, they aren't all bent up. So the engines were not running when this plane hit the ground. If we go to the next slide. Yeah. So Fitz and Jones in 1947 did a study of pilot error. They were losing a lot of aircraft like this in quite an embarrassing way. The flight crew survived a crash because it crashed while trying to retract the landing gear when you were on the runway. And they were trying to figure out why is it that so many pilots are creating this error, and how is it we're not training our pilots correctly? Allison will talk later about training being the last bastion of poor design. So they developed a critical incident technique that will be familiar to many of you on the line because we do critical incident analysis technique in healthcare. So next slide, please. So there are a few slides here. Maybe Allison, you can jump in on these first two to describe the types of problems.
So the categories that Fitz and Jones came up with are ones that I think are rather analogous to healthcare as well. But they identified a variety of categories of the errors that they accounted for during these pilot error experiences. And the first one was reach, where pilots couldn't actually reach the controls in the cockpit. Second one was unintentional activation of the various types of controls. The third was reversal. Forgetting to actually do the controls, adjustment errors, and then substitution errors. And this accounted for 50% of the errors that were recorded.
Great, thank you. So this next slide will show you where those substitution errors that resulted in a plane ending up on the tarmac. If you look down at the bottom on this central control panel, the landing gear switch and wing flap switch were co-located, very tiny switches up in the far right-hand corner. And if you were trying to land a plane in bad weather and perhaps part of your wing shot off and some injured people and all the rest of it, you might be forgiven for forgetting which one was wings and flaps. They weren't designed around the individual. They were put into production very quickly, of course, in wartime, and probably used switches and methodologies that were quite common on the day. And they relied on people just being smarter and trying harder and be more careful. So what Fitz and Jones came up with was a tactile approach to that. You didn't really necessarily have to see the switch in order to know what it was. And so they used a small rubber disc to denote landing gear and a small wedge to denote flaps. And so that became kind of the archetype, I suppose, of using a human-centered approach, human factors approach, to try to get after a problem that was very common. And so that was really the birth, I think, of aviation human factors. Alison, do you have any other comments there?
No, I was just going to say that when they did the investigation, often some of the pilots were saying that they complained of this invisible hand in the cockpit. So they really didn't understand what was happening, and they really felt that they were doing the right thing by hitting the right control. And so providing the tactile feedback and then also the visual feedback really allowed those pilots, when they were landing the plane, so in a complex type of situation, the distinguishability between those types of controls.
Yeah, good. This slide is just a reality check for us that even with new controls, these things still happen. So this is in 2009 a large transport military aircraft crashed in Bagram Airfield Base in Afghanistan. Same problem. It landed without the wheels down. So So despite our 50 or 60-year history of human factors in aviation, these things still occur.
So what we're hoping to apply now is actually give some examples of how human factors has been applied in healthcare. And so I won't be able to go into too much detail with these, but I'll try to go through them as much as possible. If you'd like some more detail, please feel free to contact me, or maybe we can set up another webinar to go into more detail. So here we have our handy little doctor saying to his patient, okay, we've established that you should eat healthier, exercise regularly, and keep your spray paint and deodorant in different cabinets. So much of the work I've been involved in has been around medical device evaluations, and so I'm going to talk about a few of the projects that I've been involved in. This one actually happened before I started at Vancouver Coastal Health, and it involved a blood glucose meter. And this involved a multidisciplinary team who purchased a device that was used to measure a patient's blood sugar. And what they were finding is that this device was designed for primarily for patient use at home, but it was being used in the hospital on a normal basis. And so on this device, it was sleek, it was very simple, and it had one orange button on it. Now, the problem with that orange button is that when you press that button, it provided an average reading for the past 5 previous patient readings. And so that was an average reading of, maybe 1 or 2 patients or all 5 of them. And so it was actually providing inaccurate information, which would lead potentially to mistreatment of the patient. And so to compensate for this, because it was already in circulation in the hospital, this bright orange sticker was designed and placed on this machine saying, do not use this orange button due to the potential for error. Now, this is a quick fix, but ultimately these types of concerns can be addressed up front by doing more formal types of evaluations. Second example I have is by some work that was done in Toronto. They were looking at new electrosurgical units, and they were finding that they were having an increasing amount of surgical teams mixing up the controls and leading to a primarily healthy tissue being unnecessarily charred. And so this was one of the, I sketched this out, but it's one of the controls that was being evaluated for purchase in Toronto. And so on the left side, you have auto cut here, which is 1, 2, 3, 4. And what that does is basically provide the depth in which the electrical pulse would be going and cutting through the tissue. And then on the right-hand side, you have auto bipolar. And what this means is that it provides a time delay to when that auto cut occurs. Now, on the bottom, you have off. 0 represented an instantaneous cut, so there was no time delay. 1 represented a half a second delay, and 2 represented a 1-second delay. So you can see that if a surgical team was working with this device, it would be very easy to confuse the controls and not program the device properly. It doesn't have to be a very complicated device either. It could be something as simple as a medication label, and I know that this is a hot topic for lots of different institutions across Canada. But at Vancouver Coastal Health, we were having some issues with the labeling of some of the medications, primarily some of the confusion between the route in which the medication was being delivered, through epidural or IV use. And so here we have an epidural bag that was an issue in that it was very difficult to see where epidural was on the label, and so an additional sticker to add to the Christmas light type of effect was added to this bag. And so what we did was actually work with a variety of different users and nurses and pharmacists to identify the workflow and how information was being read. And this was the proposed initial layout that was proposed. So having route up at the top was the most important. The next bit of information that was important was the patient's name, and then medication information in upper and lowercase lettering, but if tall-man lettering was necessary to use that as well as emphasizing the narcotic up at the top if it was present. So here we have a comparison between those two labels that I was explaining. Here we have the route, like I was mentioning, and then the narcotic name. So because the medication bag is curved, it also makes it more difficult to read. And so ensuring that this information is clear and concise is very important. And then finally, we really focused on all of the extra information that's on the label and how it made its way on the label and how we could get some of it off of the label. And so one of the pieces is that the pharmacy software just provided these extra pieces of information when really it wasn't necessarily relevant to the people who were using it. And then this was just an example of an epidural one here and a Picro one. So the next thing I wanted to talk about is some work we did with the epidural pumps last year. Now, I won't be able to go into much detail with this, but I just want you to know that there is a formal way of evaluating epidural pumps or any type of medical device by applying human factors principles. So this was work that was done with THC, so Providence, and Vancouver Coastal Health. And what ended up happening was the Abbott Pain Management Provider Pump that was in use since 1997 reached its end of life. And so the sets, all the tubing, were unavailable as of December 2009, and so a new pump had to be selected. So we put out an RFP, and we received 4 vendor responses back. So we had 4 pumps that we were able to evaluate. And what we did was we developed a multidisciplinary team, and we had representation from biomedical engineering from both hospitals, quality and patient safety, and clinical specialties in nursing and anesthesiology and pharmacy from each hospital. And so this was the process that we followed. We had the new pumps were required. We put out the RFP. We had 4 vendors respond, and then we went into evaluations. And the first set of evaluations was a heuristic evaluation and a technical evaluation. I'm going to talk about the heuristic evaluation shortly. After that time, we were able to shortlist, and then we went into rather heavy clinical types of evaluations, including cognitive walkthroughs, which are basically a way of evaluating and walking through with, in this case, it was nurses and anesthesiology, how the device would be programmed and how it fit into their workflow. And then we did usability evaluations and clinical evaluations at the same time. And so we actually had real-time use of some of the devices on the unit. And then we had a controlled lab environment where we were running nurses through use cases that were developed in typical cases of how you would be using the epidural pump. And then after that time, we were able to select a device that was clinically acceptable, technically acceptable, and then from a quality and safety perspective as well. So the goals of the human factors involvement was to first identify design problems that may affect patient safety. Second was to provide additional information for decision making. These were items because the pump had smart pump capability, which meant that you were able to program the pharmacy or medication information into this pump. What were the implementation constraints that we were dealing with? How are we going to be training this type of information? And are there any types of troubleshooting things that we needed to address? And then finally, we wanted to quantify the level of consistency between the device and the current workflow and the degrees of standardization which were acceptable. So when I say a heuristic evaluation, what I'm meaning is a discount usability evaluation technique. And so it's very easy to apply. And what we did was use this as a first step in evaluating usability. So we applied these general guidelines or informal rules of thumb to evaluate the pumps and come up with a list of criteria, identify violations to our criteria, and then assess the severity of each of these violations. And it's important to note that we also identify positive and negative features. And so what we did in this situation is we had me as the human factors specialist. I trained 2 biomedical engineering representatives to also administer this evaluation. And then also we included 3 nurses. So we actually had 6 in this circumstance. And each person was presented with the pumps. It was counterbalanced, and so everyone had a different rotation or presentation to how they were going to be evaluating the pumps, and this was all done independently. And the benefits of this is that it's rather low cost and low time commitment. It's easy to apply, and it helps in improving design and redesign. So we're actually able to specify to the vendor some of the concerns that we have. And so this was the flow that we followed. We identified the issues. We determined what heuristics were violated. We assigned severity ratings, and then we made recommendations for improvement. So I'm going to show you an example. So we wanted to first evaluate the device that we were replacing for a couple of reasons. We wanted to know what the current workflow was, and then we also wanted to know how we would be selecting a new device and how we would have to untrain and retrain on the new device. But we also wanted to know what this device was going to be competing with in the environment. And so on the left-hand side, we have our epidural pump, and then on the right-hand side, we have our PCA pump. Now, these are 2 pumps that you wouldn't want to be mixing up simply because of the types of medication that are being used and the route that the medication would be administered. But as you can see, there's some discrepancies between these 2 pumps that were in operation at the same time. First one was the keypad. So on our epidural pump, we had a numeric keypad that had the 7, 8, 9 up at the top. Now this is very similar to your computer keypad that you would see and is often used for accounting or quick numeric inputs. Whereas on the PCA pump, we actually had a keypad that had a 1, 2, 3 up at the top. And what this was is similar to your phone, your cell phone, your ATM machine. And so when you look at these comparing, if you have a nurse going from an epidural pump to a PCA pump, it's very easy for this nurse to confuse potentially that 7 and 1 or this 3 and 9. So you can see that there's some concerns there. The other things that were a problem were the enter buttons on opposite sides, and those were switched with the start, stop, run, start, pause, and run, stop buttons. And so what we did was, taking that information, we actually applied a set of heuristics to the 4 devices that came in for evaluation. And these are an example of the heuristics that we used. The next thing that we did was assign a severity rating to each one of the violated heuristics, so 0 being not a problem at all, to 4 being a severe usability concern. So this is an example of how the information was presented. So one of the issues we found was that there was no clear way to exit the bolus dose screen without giving a patient bolus. And so what we found is that the evaluator, because they couldn't get out of the screen, they ended up hitting the bolus dose quickly and then hitting it again. So you're actually in a moment where you're giving a free flow of medication. And so the heuristics that it violated would be user control and freedom, consistency and recognition rather than recall. So there was an actual way to get out of this, but the user could not find that. But when we're talking about user control and freedom, it's allowing the user to be able to go back or go forward depending on what the controls are. So this was obviously a severity rating of 4, and we recommended that they provide a clear exit that would be distinguishable for the user. Another one was that the drug rate and concentration could be changed manually after the user had selected a protocol. And so what ended up happening was, if you wanted to go from, say, like 8 milligrams to 10 milligrams, and you go back and you hit 8 and then you hit 10, there was an option of using the arrow down button rather than an enter button. And so what ended up happening is that you would hit arrow down, and the change you just made did not actually take on the machine. So the assumption was that it did change because you physically did it, but the pump actually reverted back to the previous setting. So what the recommendation was is that there was a confirmation that must be present, ensuring that the user accepts the value and moves forward. So with our epidural pump heuristic evaluation, this is what we ended up finding, and these were, I'm just showing you the maximum severity rating. So these were the very serious types of concerns, and as you can see, pump A had 28 violations, pump B had 17, pump C had 3, and pump D had 2. Now, it should be noted that pump A, before the evaluation occurred, was the one that was being strongly encouraged for purchase, as I found out after the fact that it was the cheapest by quite a significant amount. But what we were able to do is show from a quality and safety perspective and from a clinical perspective that these two pumps were not acceptable to move forward into clinical and usability evaluations. And so this was the flow that continued going on. We did a cognitive walkthrough and then usability evaluation and clinical evaluation, and we ended up selecting a device that we're receiving rave reviews about and that the users are quite satisfied with. So I'm going to pass it over to Ray.
Thanks, Allison. Awesome work. Yeah, this is crucial information so that we can evaluate devices before we buy them. Try before you buy. I'm quoting some of the group from Calgary who have done just that. Next slide, please. Yeah. So there's been quite a tradition in anesthesia and critical care of human factors. Back in the 70s, they used the critical incident technique back in the late 70s to evaluate anesthesia mishaps. The slide on the left is I'm going to see if I can use this pointer here. There we go. Okay, there we go. So the slide on the left is an older anesthesia gas machine where it is possible to turn on two vaporizers for two different volatile anesthetics at the same time. That had been corrected early in the anesthesia care world, and now these devices are interlocked. You cannot turn on more than one volatile anesthetic gas at the same time. So they have a mechanical interlock because an anesthetist is a pretty busy individual and may forget these things. So that's the idea there. Next slide, please. So I want to wrap up a little bit with Allison's work with device procurement. In my experience in critical care for a long time, I was often involved in evaluating pieces of equipment. We'd often evaluate it in the back room behind an ICU, not in context, and it was around preference, cost, what influences there were in the system, including which company was the proponent, and clinical experience. There wasn't a lot of background in prospective human factors usability testing. Those words really weren't used very much. I'm delighted to see them being used more now. More and more companies are being required to do this. You should be very careful to make sure that if someone says they do a human factors evaluation or usability testing, that it is scientifically based and that someone with some credibility and perhaps a third-party academic person should have done that. We've been working with and communicating with the Shared Services Organization to try and influence that group, because it's a new BC group, to try to incorporate usability testing in medical devices. On the CBC News today, some of you may be aware that there's a device recall on an infusion pump that is commonly used. That's only in the United States, and we've had some discussion today with the group in BC around what that means for our care in our hospitals across BC. So this is incredibly topical, and just today we've been having some fairly high-level conversation about usability testing and what devices are appropriate. This is a picture of an intensive care I used to work in. Intensive care unit. You can see that all of the devices are different. They were, I can tell you that they were purchased at different times by different people. You have extracorporeal membrane oxygenation and heart bypass going on in the ICU, in a pediatric ICU. You have a mechanical ventilator in use, certainly, and you have, of course, the teddy bear. And all of the infusion devices, you see all of the stickers, and you remember back to Allison's sticker on the epidural bag. If you crank up the complexity, you multiply that by an order of magnitude or so, you see the complexity that we deal with in healthcare. So although this may not look like your intensive care unit, I hope, it is a complex world out there. And we are jury-rigging all the time. We're making workarounds because the devices don't fit us. There's a label right there on an IV bag. Just be more careful, essentially. So with that, I'm going to move into what we try to do to try to learn from adverse events in healthcare. There's a perfect storm out there. Patients are getting more drugs. Polypharmacy, I think, is a real recognized problem. We have higher numbers of elderly patients with more comorbidities. There's less continuity of care in terms of fewer people have identified general practitioner, and the burden of chronic illness and comorbidities. It used to be in the intensive care unit where I worked, you had a person with an acute problem that may have had an underlying chronic condition. Now it's common that people will have 3 or 4 underlying comorbidities, and it's quite common to do intensive care sorts of things outside of the intensive care, which adds a lot more complexity. And then, of course, a lot of healthcare workers are aging. So in the next slide, I talk a little bit about hindsight bias. When an adverse event occurs, it is very easy to judge to try to judge what was going on in the practitioner's mind. And because you know what happened, it's very easy to trace the trajectory back from what happened to what was going on at the time from this perspective. That discounts all of the complexity that was on that preceding slide. It discounts all of the complexity, interruptions, mislabeled devices that were never designed to work together. And so David Woods talks about that the future is implausible and the past is incredible. The idea there is that hindsight is a bias we really need to protect from. So when we do an investigation, we need to do it including the person who was involved, who had the last sharp thing in their hand, and really seek to understand their perspective. And if we don't include them in that investigation, that investigation is going to be a very thin description of what occurred, and more than often, more likely wrong. Next slide, please. So human error is now thought to be a symptom rather than a cause. The old view, or the bad apple theory, and this is where I refer back to Newton and René Descartes, they would say that complex systems are basically safe. Isn't healthcare safe after all? And that errors are the result of erratic humans. And you'll have seen Swiss cheese models and other models that really just trade the blame on, okay, it wasn't the individual, it was the system, and it wasn't the system, it was the government. So that's sort of a middle ground between these two views. The new view is that human error is a symptom of deeper problems in the system. And you try to understand from a practitioner's perspective how their decisions and judgments and assessments made sense to them at the time. And Alison was talking about this certainly in her work, and I just ask you to think about that slide I showed you of that intensive care unit. People get up intending to do a good job, but they're faced with incredible complexity. So it's now very clearly recognized that complex systems are not inherently safe. The Baker and Norton study, was the Canadian version that talked about that. These systems are dynamic trade-offs between multiple irreconcilable goals: efficiency, safety, production. And so people are trying to balance that throughout. So if you're in a situation where you're called upon to do an investigation, having some of this background is very important so that you can frame it correctly. And the best compliment you'll ever be given is if you're invited back to do a second investigation. Next slide, please. Yeah, so when you do an investigation, it's not enough to just make recommendations. I actually don't like the word very much. I like locally actionable improvement. those recommendations or those improvements must be realistic, appropriate, and measurable, and done in a way in which you can audit them. And the people who are involved in actioning those things, of course, need to be at the table and need to have the resources, tools, money in order to pull that off. So some of the best and easiest ones are forcing functions, where you can change a device or a piece of technology. Much harder to change behavior, and the least effective is writing a poster and putting it on a wall somewhere, or education. And again, training is the last bastion of poor design. So forcing functions and automation is a better way to go to try and remedy some of these. And I have some examples that some of you have seen that will remind us of them. So here's an example from 2005. There was a death resulting from a patient receiving air rather than oxygen. He was actually receiving both simultaneously. This is a problem as a respiratory therapist I had seen over the years again and again, and was able to suggest with some other individuals ways to correct that. So the airflow meter was the very same design. It's called a Thorpe tube, and these are ubiquitous in healthcare. The protections end at the wall outlet because these things are diameter index safety systems, and so you are quite obviously able to hook up an oxygen tubing or air tubing to any one of these two things. So while we weren't able to correct the fundamental problem, we did use, we did remember what Fitz and Jones had taught us about gears and flaps. And so we had actually changed the device. So this is a restricted orifice. It will only give us 7 to 8 liters a minute of air. That's what you need if you're going to nebulize some medications to somebody. It's a tap rather than a rotameter. So you really don't even have to be sighted to know the difference between air and oxygen. So we made that correction, we tested it. This wasn't an out-of-the-box thing. We actually had to make this from a bunch of parts. And some of my RT colleagues are pretty good at Lego, so they put that together. And so we tried that, and then we tested it, made sure it didn't have any other adverse consequences, and then we implemented it across Interior Health. So there are 1,500 of these, and in Interior Health you cannot buy a flow meter. Here. So that's the other piece, is make the right thing easy to do and make the wrong thing harder to do. And with our purchasing department, you can't buy one of these things right now in Interior Health. Next slide. Here's some work I did with the group in Kelowna General. I think Callum's on the line as well, and we worked together on this. This is a series of near misses in transfusion practice. And I mentioned earlier the Meditech, my love of the Meditech order entry system. There were a series of 8 near misses in transfusion practice, and we found that they clustered around the order entry phase. The problem was that you could order blood on any SMED. So they created early at KGH a method for identifying the date of birth and something that wasn't on the screen in front of you as a verification step, and solved that problem. Again, it was tested locally. There was a problem in that if you didn't have a date of birth, you may not get blood. And what would happen about that emergency patient who came in suffering the trauma? So we had to develop a workaround for that. We tested that for 6 months, and then the IMIT clinical group took that and implemented that in all the modules in Interior Health. So anywhere there's a Meditech blood bank module in Interior Health, it has this system fix embedded in it. So we fixed this, we changed the systems in which people work rather than trying to write a note and just say, be more careful. Next slide, please. Yeah, so just a summary here, and our learning how to learn from adverse events, the main summary point I want to make, I think, is that these fixes are never quick. Those 2 cases I just talked about took months to do. Our reaction to failure often prevents us from learning from it. So that's our propensity to who channel Newton and Descartes and get into hindsight bias. So that's a real problem that we have to be aware of. Quality of care reviews are about people in complexity, and so they have to be sensitive to the practitioner's lens, what was going on at the time. And finally, both patients and healthcare providers need the facts and they need peer support. When an adverse event occurs, it's devastating for the family and the patient, but it's equally devastating for the well-intentioned nurse, physician, therapist who is working in a very complex system. So a few conclusions then, and I'll ask Allison to have some comments as well, but really human factors is about being proactive. It's about creating a system that's easier to work in rather than reacting to harm. When we have to react, we do so in a sensitive way and a respectful way. And we identify the cognitive processes to improve the systems in which we work. Allison, do you have a few closing comments?
And just in terms of analyzing the potential adoption of new technologies for user interaction and performance, training is really, I think, the last bastion of poor design, and that comes from one of my previous supervisors in Calgary. And when you look at these types of systems or tools or technologies, when you incorporate it and say, oh, we're just going to develop an education program or a training program or posters, yes, they are helpful, but in
or write a policy, right?
But in terms of that, So, but one of the things we found really interesting just from our epidural study was the amount of time that it took to train people on a device that was very easy to use and very user acceptable was at least half. So it took 15 minutes for one and 7 minutes for the other. And so focusing on things that are designed well, that work for users, and that ultimately are safe and provide quality care is of most importance. So thank you very much. I'm going to turn it over to Andrew. Here's I have one more slide, I believe. So these are some human factors readings. We have a list here. I recommend The Human Factor by Kim Vicente, that book, and also Decker's book, The Field Guide to Understanding Human Error. Both of those books are very easy reads. They're very applied and logical, and are ones that you can read at home and are very interesting. So I think they're interesting. I don't know about you, Ray.
I agree. I'm into easy reads. And those two I would absolutely recommend. Yeah.
The other ones are textbooks. So we're open to receiving any of your questions. I'm going to pass it over to Andrew. And
if there are any questions from any of the participants, there's a couple of options. You can either type them into the chat box, or else a good way of doing it is to raise your hand, which is the small icon of the hand directly near that arrow. And we have one question that came in. Any tips on when to know if you should be looking to apply a human factors lens in your improvement work?
On when to know? Well, we're working on that. From my perspective, I'm trying to work on some tools to help with that. As bad as it sounds, I often go with my gut feel. If something just doesn't seem right, or if you're dealing with frustration, or people are angry about some sort of development, those tend to be the red flags for me.
I would say that as well. The lean methodology is becoming quite common now, and this, you can think of this as an extension of the philosophy of you're really trying to understand from a practitioner's perspective and reduce waste. And so you can do that when you have the opportunity to buy a new device. I think that's a great time to think about human factors up front, because that device, depending on how complex and expensive it is, that's going to be with your organization for 10 years. So you're going to magnify the frustration or the goodwill. Before you buy a device, absolutely. I think when you've got a problem that's in front of you, and there's a really good example, I think, in Callum and the group, I think he's at Kelowna and other places. Just human factors can be fairly straightforward, like cleaning up your narcotic cupboard and putting the labels in the correct way and ensuring that you've got the right medications with the ones they're supposed to be with and getting rid of clutter. So on a fundamental, simple level, getting rid of clutter, some of the lean methodology, is actually some applied human factors work.
Jerry, do you have a question there?
Yeah, I almost hesitate to ask it because I want to say, first of all, I love the concept and very well done, fascinating stuff to me. My only concern is, I guess and I hate to even say the term, I know you're going to cringe when I say idiot-proof. I have a design friend of mine who said, whenever you're trying to make something idiot-proof, nature is trying to invent a better idiot. Yeah. And I really don't want to come across as negative on it, but is there a risk that we're kind of deleting individual responsibility a little bit? Because I've had occasions where, and in the interest of time, I'll be very frank, I've had occasions where someone did something not very smart, made a mistake, and admitted that, I shouldn't have done it this way, and yet the tendency was to look at changing the entire system when really occasionally there are circumstances where somebody just does something wrong, and does it necessarily mean that we have to change the system, and are we maybe swinging the pendulum a little bit too far? And again,
I'll take that first.
100% with 99% of what you said.
I think you're correct that you can swing the pendulum too far. So we have a policy, for instance, that professional responsibilities are known and understood. Where there are systemic factors that have overridden that, then we will do a detailed investigation to look for those systemic factors. But in policy, in our critical incident policy, we have the requisite that professional standards are known and understood. So a person who's a respiratory therapist who's doing critical care and managing life support, they are required to know how to operate and to integrate that mechanical ventilator with that critically ill patient. But notwithstanding, there are poor designs out there. So I absolutely agree. The pendulum can swing too far, and I've certainly seen at senior executive levels, look, this was not a system error. Someone screwed up. And occasionally, that is the truth. In my experience, the reason that they screwed up was a result of all kinds of complexity and goal conflicts there. So I take your point. Absolutely, it's not simple. And the pendulum can't swing too far. But certainly, individuals are absolutely responsible and accountable.
I would agree with you as well, Ray. I often say that I have a degree in common sense because when you think of human factors and the way that we presented it today, it does sound rather simple. But when an example I can think of is with the epidural pumps. The way that we were looking at those epidural pumps was to really understand how users are doing their work. So there's a difference between, what the policy says and how they should be doing it, and then also looking at how they actually are doing it, because we all know that there are those shortcuts and those quick workarounds within an environment. Now, what my intention was to really look at what the workflow was and to ensure that we were matching the workflow as best we could, but also to provide those safeguards in place where, codes were in place, where you had a safety code, so somebody who wasn't authorized to be using that type of device would be involved with it. So other applications of the human factors area could be something like the surgical safety checklist and looking at team behaviors and how people are interacting in an environment. But your point to being about people who, like negligence or people just not doing what they should do, that we can work around it, but ultimately there is some responsibility still to the user and the intention of how they're going to complete their task is factored into how we make recommendations.
So we've got another question here that was typed in, and it's how do we go upstream and ensure that standardization is built in? We wouldn't accept an auto that had the accelerator to the right of the brake. Why do you allow technology companies choice in numeric keypads?
Very good question. So this comes down to the standardization of regulatory bodies and how devices are evaluated. And so I'm going to make a point about the FDA. I know that's not specifically related to Canada, but the FDA mandated in 2004 that medical devices in the U.S. have full human factors evaluations incorporated into their design cycle. So when they're designing a new device, that they would actually have that type of evaluation. Now, there's subjectiveness on how rigorous that type of evaluation is and how the company has actually gone about it. But I think it's really important that hospitals and institutions take ownership of what they're bringing into the environment. So why don't we have requirements of how we're standardizing? I know we have the SSO looking at the province now, and quite honestly, I don't know if a pump in Vancouver Coastal Health would be just as safe as a pump in Interior Health because of all of those other confounding technologies. So I would agree with you. I don't know if I have the answer. Ray, do you?
No, that's a great answer, I think. Yeah.
So the approach that I'm taking is the responsibility of evaluating things, kind of being a gatekeeper. I'd like to be a gatekeeper anyways, but really
maybe I can add. I mean, we're trying to have some influence in the province to. We have an opportunity now with a common procurement system to have some standardization where you didn't have that opportunity a little while ago. So that's where we're trying to use that influence and some experience to affect change and standardization, at least at the provincial level.
And not being the component, but being a part of the component. So being a piece of the puzzle. So there's a multitude of other factors, but just having an awareness of what these types of decisions and the impact that they have.
Okay, we're at the end of our time here today, but I would just like to thank Ray and Allison for such an interesting presentation. We really appreciate you taking the time to do it today. And to all the people out there who came on board and listened for the session. We are having a number of other sessions offered by the Council, so be sure to check our website regularly or sign up for our newsletter and you'll be told all about them. The one final thing is that we do have a survey that will pop up when you close the window, and we really do appreciate your feedback, and it's a great place to let us know what other sessions you think would be valuable, both as a continuation on the discussion of human factors, as well as any other topics that you think would be useful. And with that, once again, I'd just like to thank Ray and Allison, and we'll sign off.
Okay. Well, thank you very much for your time.
Thank you.
Bye.